Gabriel, maybe it's just you and me. You there? Maybe it's just me.
Oh, sorry. I was muted.
Oh, okay. There's Jaslyn. Okay. Well, if you heard the joke about the preacher one night, he showed up at church, horrible storm, horrible blizzard. And one other guy showed up, old farmer showed up, just he and the preacher. And so the farmer said, our preacher said, oh, it's just us. What do you want to do? And farmer said, well, you know, preacher, if I went out to feed my cows and only one cow showed up, I'd still have to feed him. And so he goes, you know what, you're right. He was inspired and he reared back and he unloaded both guns, both barrels on him. Fire and brimstone gave him the whole shooting match. And at the end, the farmer goes, preacher, that was a mighty good sermon. But he said, you know, that cow I told you about, I would have fed him, but I wouldn't have dumped the whole truck on him. So I guess maybe one good thing, if it's just the three of us, we can kind of focus on what you guys want to go over the most. And I'll just kind of start off on some stuff, and then you guys can say, I need less of that or more of this. Okay. Jaslyn, that makes sense to you? You're muted if you're talking. She may have stepped away or something. Let's go ahead and get started then. I'll show you, but I want this to be interactive because the only way you get anything out of it is, trying to respond to what I put up here. And because I actually kind of know this stuff, so I don't need to go over it myself. All right. So, same thing you've been looking at for 3 weeks here, the pituitary. So why don't you just tell me what those letters represent? Oh, let's see, I need to share my screen. Sorry. That'd be a little tough. Let's see, here we go. Okay. You see my screen?
Yeah, I can see it.
Okay. Why don't you run through those letters then and tell me what they represent?
Okay. B is the adenohypophysis, or the anterior pituitary gland. C would be the neurohypophysis, or the posterior. D and E, I believe we spoke about that yesterday, and you said it wouldn't be quizzed on, but they were the neuro side of the neurohypophysis, right, which triggers the release of those hormones.
Yeah, the only way they would be on the test is if they had a model and they put a sticker on a model up there and ask you. And I think they have some blown up models of the pituitary, hypothalamus, and pituitary. Anything you see preoptic nuclei or paraventricular nuclei, I don't think they'd ask for that kind of detail, but okay, those again are where, and key here is oxytocin and ADH are secreted, because those the osmolality receptors that trigger ADH sit up there, and other receptors for oxytocin. So they're secreted there, released in the posterior pituitary. Good job. All right, Jaslyn, you're up. But you name these lettered items here. You there, Jaslyn? I think I can unmute people. Here I can't.
She said she's like at like the library or something and can't use her mic.
She what?
She's at like the library or something and can't use her mic. She's out in public. So
Oh, okay.
yeah, I think she's just gonna be doing some listening.
All right.
Yeah.
You want to take this? Are you there, Brian?
Yes, I'm here.
Okay. Why don't you take this slide?
I'm not sure.
Okay. Let's start off. A up there is pointing to blood vessels. Those are capillaries. Where are they?
In the hypothalamus.
Hypothalamus. That's right. And then E is also pointing to capillaries. Where are they?
In the anterior pituitary.
Anterior pituitary. So they're connected by B, which are also some blood vessels that connects those two. So what do you think that might be? Starting with hypothalamic.
Hypothalamic anterior blood vessels.
Hypothalamic hypophyseal portal system. So that's how the all the releasing hormones, TRH, CRH, GnRH, gets into the anterior pituitary to stimulate those glands to release TSH and ACTH, etc. Okay.
Okay.
I'd remember that one. That one very well, maybe on there.
Can we just call that the hypophyseal portal? Do we have to say the hypothalamic?
Yeah, that'd be okay. I think
Okay.
that covers it as well. Well, I can guarantee you that since I'll be grading it. Yes. So look at, if I told you that tissue labeled ACB over there is from a pituitary, what parts of the pituitary would each of those letters represent, Brian?
I'm not sure the question.
Okay, so A looks different than B, and C we haven't talked much about, so I might pass on that one. But between those two makes up two major parts of pituitary. Which is which? So there's an anterior pituitary and a posterior pituitary. Which would represent the anterior pituitary?
C.
Nope. That's the pars intermedia, which is a little part that just secretes melanin, or MSH, melanin stimulating hormone. So A is the anterior pituitary. So it's glandular. I don't know if you were on last night, but I think you were. We talked about how it's glandular, and so it stains darker than B, which is the posterior pituitary, and it looks more like nerve tissue, doesn't stain dark. So it'll always be the lighter one on any histologic section. The posterior pituitary will be the light side. Okay.
I ask a question?
Yeah.
I don't know if this really even pertains to the test, but I remember hearing that there's a reason why it stains darker. Wasn't that was that basophils, or was it used like why does it stain darker? I can't remember which cell it was.
Well, they're the secretory components of those cells. So they accumulate the stain, basophilic stain, the dark stain. Okay.
Well,
Whereas there's no secretory cells. There's no vacuoles that are ready to secrete that stuff in the posterior pituitary. Again, it's the neurohypophysis. So the hormones are just released from the ends of the nerves in the posterior pituitary. All right.
So you said it did have to do with the basophils. You said basophilic.
What's that?
You
Sorry.
said it did have to do with basophils. It was the basophilic.
Yeah, well, basophils are called basophils because they are take up basophilic dye, but a lot of anything that has secretory cells in it takes up basophilic staining. Okay, Gabriel, you're up. Why don't you assign a hormone that stimulates one of these targets to each of these lines coming out of the pituitary?
Sure. So for the adrenal cortex in particular, but just the adrenal gland would be the adrenocorticotropic hormone. That'd be A.
Right.
B would be thyroid stimulating hormone.
Right.
That'd be going to the thyroid gland. C would be growth hormone, which goes to the liver and then goes to the somatostatin cells or whatever.
Uh-huh.
D is prolactin, that goes to the mammary glands of the breast. E and F are follicle stimulating hormone and luteinizing hormone.
Correct.
And they go
Yep.
to both sets of gonads are for the men and women, so testes and ovaries. For G, that's oxytocin, which has to do with uterine contractions, I believe, or something.
Yeah. Yeah.
And then H would be antidiuretic hormone, which goes to the kidneys to help regulate
Perfect. Good job.
sodium or something.
Yeah. Very good. Any questions about that, Ryan? Brian?
What is the MSH thing? Do we need to know about that?
FSH?
Yes.
Yeah, FSH, follicle stimulating hormone. Just know that it stimulates the gonads. So in the male, it stimulates spermatogenesis and contractions, and then in the female, it's part of the menstrual cycle. So it stimulates buildup of endometrium when it's released once a month. In the male, you may remember that even though it's released all the time, not until testosterone starts being released at puberty does the male start producing or start off with spermatogenesis. And then the two of them together can produce 300,000 sperm an hour. So the two of them together are synergistic. That's I don't think that will be on the test, but one of the things that they talked about. But they both act in both male and female. Okay. So, Brian, this is thyroid. I'll just tell you that up front. And thyroid has some characteristic things that just seeing the histologic section just jump out at you. So first of all, what are those big pink globs in this tissue?
The follicles.
Yeah, thyroid follicles. You know what they're filled with?
No.
Yeah, that won't be on the test anyway, but it's thyroglobulin. And so that is actually stored thyroid hormone, and it's stored connected to this huge protein called thyroglobulin, which is what that jelly or gooey type stuff is, filling each of these follicles. And so what are those cells that surround the thyroid follicle?
Follicular cells.
Follicular cells, right? And how about the those cells that are labeled C?
Parafollicular cells.
Parafollicular cells. You know what they do?
No.
They're also called C cells. That actually stands for clear cells, but I always remember that it also means that they secrete calcitonin. So those are the ones that are responsible for releasing calcitonin, which kind of counters the parathyroid, right?
Can I ask a quick question? The thyroid follicles, are those also called colloids, I believe?
Thyroid follicles called what?
I could have swore I saw it in like the presentation colloid.
Oh, yeah. Actually, the material inside is called thyroid colloid sometimes.
Okay.
Okay. Yeah, that's a good question, actually. So, but yeah, thyroid follicle is the official name for those things. And then the cells that line them and go all the way around, kind of create a little capsule around it, are those follicular cells, and they are what actually make the thyroid hormone. So they produce the thyroglobulin. They also bring the iodine in from the bloodstream from the other side of those cells, and then they iodinize the amino acid that makes thyroid. And so you'll know what that amino acid is. It's called the monoamine. There's only two hormones that are made with this amino acid, single amino acid.
And those the follicular cells, are those cuboidal epithelium?
Yep. That's the type of cell they are. But it's tyrosine. Tyrosine is what thyroid hormone is made out of. So it's a little tiny hormone attached to this huge thyroglobulin. And so those things are iodinated, attached to the thyroglobulin. They match up and create two tyrosine molecules joined together with either 1 to 3 or 4 iodine. So that makes up the hormone T3 or T4, right?
And you said that was the thyroglobulin that produced that?
The thyroglobulin is actually the stored thyroid hormone, and then when
They make
thyroid hormone is released, the
monoamines?
thyroglobulin is taken into the cell, and those the thyroid hormone is broken off of that and put into the bloodstream.
And so wait, so how do we get to the amines? What were they called?
Oh, the tyrosine it's an amino acid. Okay, it's just used to make up lots of proteins, but it's a single amino acid that makes up thyroid hormone. All right. So Gabriel, look at this little table here and see if you can fill it in for me. So you've got hypothalamic hormones here, and we talked about these pituitary axis and how these hormones create this axis of or chain of events that starts in the hypothalamus and stimulates a releasing hormone and then a actual hormone. And so what's the chain in each of these for each of these releasing hormones?
So for the first one, I believe that's thyroid releasing hormone,
Right,
and that would release thyroid stimulating hormone,
right,
which the target organ would be the thyroid.
right.
Um, I'm not sure what CRH is.
Take a guess.
Hmm. Oh, is that? I was gonna say like calcitonin releasing hormone, but
Mm-mm. Think of what other hormone is released from the pituitary that would stimulate something that starts with a C.
Is it corticotropin releasing hormone?
There you go. Good job. Yep.
and that would target the adrenal cortex.
Right. ACTH
Okay.
and the adrenal cortex. Yeah. And we haven't talked near as much about gonadotropin releasing hormone, but of course it stimulates FSH and LH, and they stimulate the ovary and testes that make estrogen and energy. Okay. These are random letters that I just accidentally left up there. But you recognize this dreaded picture. Brian, you know what that is?
The zones of the adrenal gland?
Yeah, the adrenal cortex. You remember those? Starting on the outside, working in.
Zona reticularis?
That's number C down there. That's the bottom.
It's zona glomerulosa,
Uh-huh.
zona something with an M.
Fasciculata. So you think of fascicles. You see these kind of vertical lines in there. Those the fascicle is kind of like a bundle of sticks or a bundle of things. So those vertical lines reminded somebody of fascicles. So that's fasciculata. This is, if you look real close, little globules. So that's glomerulosa, little balls. And then this looks like a fishing net or reticulum. So it's called reticularis, just based on their looks. And this is a better image than you've seen before because it accumulates this brown stuff down here from shoot, I'm trying to remember exactly what that is. I think it's some iron accumulation, but this releases what? Glomerulosa.
It starts with an A. It's I can't remember the name.
Really, the category or what the organ that it stimulates? It's aldosterone, and it's a mineralocorticoid, so it's responsible for fluid and salt balance. So it works on the kidney to preserve sodium. And then fasciculata is glucocorticoids, cortisol and hydrocortisone. Those are your stress steroids, and then reticularis is androgens or testosterone.
Doesn't the reticularis also produce glucocorticoids?
Yeah, yeah, yeah. It's kind of balanced between the two, and fasciculata also produces androgens as well. And then D down here is the adrenal medulla.
Will we be counted off if we happen to not spell fasciculata correctly?
Fasciculata. I'll probably give partial credit if it looks like you were on the right track. But I know the lead position wanted us to score for spelling as well, but we get the final say in that. So I'll give you some credit if it looks like you know what you're talking about or you're heading the right direction. Okay. So I put these up here for a reason, side by side. And I'll just tell you what I'm looking for here. There's two different kinds of slides that you can see that have these nodules in them. Okay, and one might be a thyroid, and you're looking at parathyroid attached to it. So whenever you see a nodule in a specimen like this, look for follicles. Okay, so if you see thyroid follicles, that's a dead giveaway that this is a parathyroid and not what this is over here, an islet of Langerhans in a pancreas. Okay, so I could see somebody being mixed up on that if those were maybe side by side or without a lot of explanation and just given the stress of taking a test and everything. So this nodule will be bigger to the parathyroid because you're looking at a whole gland. This is that little square blown up. And so B there is labeling what are called chief cells, which are the ones that secrete parathyroid hormone. And these are called oxyphil cells, I think, and nobody actually knows what they do. So I don't know why we even label, I guess just to show that they're different. So then this is an islet of Langerhans in the in the pancreas. And so what are two main kind of cells that are found in there, and what do they secrete? You know that, Brian?
I'm not sure.
Okay, what does the pancreas what hormones do the pancreas secrete? The absence of one causes diabetes. I'll just tell you that.
It's insulin and is it glucose?
Glucagon, right. So one pushes the blood sugar up and one brings it down. So insulin reduces the blood sugar, driving glucose into the cells, and glucagon increases the blood sugar by mobilizing glycogen stores. So beta cells are what produce insulin. So that's the main one to remember. Alpha cells produce glucagon.
Okay. And we find that in, I believe it's infants, that the beta cells are traded out for gamma cells.
Actually, juvenile onset diabetes is caused, we think, by an autoimmune attack on the beta cells. So you have maybe a virus or something that produces an antibody that destroys the beta cells. because there's two types of diabetes, as you may know, type 1 and type 2. Type 1 is juvenile onset, usually occurs before the age of 18, and these people die without insulin. So they're called insulin dependent diabetics. Type 2 diabetes is the diabetes of old age. It's more common, or not old age, but develops later on in life. And they think that that's related to that process that we talked about briefly called downregulation of the receptors. So your receptors don't work as well. So we try to just push out more insulin to kind of flood the receptors with more insulin. But typically these folks will not die or go into what's called ketoacidosis without insulin, whereas juvenile diabetics will.
Yeah, I just realized I was thinking about hemoglobin, that the beta cells in fetuses are replaced with gamma cells, but yeah,
Okay.
just mixed up.
Well, that's kind of it for endocrine right now. You got any questions before we move on?
No, nothing. That's just what I got confused on.
Okay. Brian?
Is there a difference between the alpha and beta cells between the pancreas and the hemoglobin?
Oh, so in hemoglobin, it's not beta cells. It's a beta protein. We'll get to that in a minute.
Okay.
It's an alpha chain and a beta chain, and you have two of each that make up a single hemoglobin molecule. But yeah,
I got that.
alpha and beta was used to designate variations in both of those. Okay, going on to the heart.
Before that, sorry, in the before slide, the left one was pancreas and the bottom right was thyroid. I missed out on what the top one was. Top right.
Sorry, you're gonna have to start over there. Jasmine, what were you saying? Fourth slide?
Sorry, the slide after this, the histology.
I believe she's talking about slide 8,
Oh, 8?
the one we were just on.
Okay.
Can you go over what glands they are again?
Yeah, this one on the left is pancreas. And this is parathyroid. The reason I put them side by side was to show you that it might be possible to get confused given they're both kind of nodular looking. And if one is blown up real big and the other one's not blown up as much, it might be easy to get confused and think one is the other. So realize that the one on the right, parathyroid, is going to be surrounded by thyroid follicles. That's how you would tell the difference in that situation. Otherwise, they're totally different, obviously, and totally different glands. But if you're just looking at tissue specimens lined up side by side, somebody might be confused by that. Islets of Langerhans versus parathyroid gland or nodule. Okay. Did that answer your question, Jaslyn?
Yes, thank you.
Uh-huh. Okay. So we haven't really talked about this view of the heart before, but I thought it offers an interesting perspective of the pulmonary artery that you don't usually get to see, and how it lies really in front of the aorta. And I think so many times people mistake the pulmonary artery for the aorta. And if you get the heart oriented correctly, it has this peculiar angle to it where it's taken off toward the left lung, and has 3 branches because the left lung has 3 lobes, the right lung only has 2 lobes. And then the aorta just goes over the right pulmonary artery. So I think that makes that a little clearer, and just one more way for people to kind of help differentiate that. What this also shows real clearly is the pericardial sac, and on several occasions I was comparing that with the pleural, the pleura. So the lung is covered with the same kind, in the same kind of sac called a pleura, and you have a visceral pleura and a parietal pleura, and it's the visceral pleura that lines the inside of the chest. The I'm sorry, the parietal pleura lines the inside of the chest. The visceral pleura lines the lung and the heart. So because that pleura is that visceral pleura is just almost inextricably bound to the heart, we also just say that's the epicardium. Okay. So what the function of those are that they secrete a serous fluid that allows those organs to move back and forth easily. So lungs have to inflate, deflate, they move up and down inside the chest. The heart obviously moves inside that sac. And so kind of keeping that whole motion lubricated so that it's protected and isolated.
So when asked, would we tell them the epicardium, or would we tell them the visceral pleura?
They should make it very clear if they're trying to get you to point out the visceral pleura. So I don't think that they would actually even ask that. But it'd be fair to kind of, ask them, are you going for the what's covering this, or the first layer of the heart muscle, something like that. But usually what you're going to see is just the membrane pulled away from the heart, and it would just be looking at the pericardial sac itself, or the parietal pericardium. All right. So this is myocardial muscle. And I think we only have one or two, well, maybe have a couple of different images stained in different ways. But essentially what you see is this striated muscle, which is a highly efficient muscle loaded with multiple mitochondria. The one thing that you can see on those images are these intercalated discs. And I haven't seen that I didn't see that on the quiz. And I don't know if it would be marked on the test, but it could be. So I'm saying that because I won't be marking your test, as you know. So the professor ahead of me, who has the class just before our 6 o'clock class, is going to just leave all of his marks in place. He's been teaching this class for quite a while, and so he knows how to mark things well. And we've talked about, we're pretty much on the same page as far as what we're covering. So I don't think there'll be any surprises there. But as far as things that are obvious to be able to mark, other than just asking what kind of tissue is this, which is myocardium, and it's a pretty distinctive look. It might be these intercalated discs, which are the junctions between myocardial cells. And that's this thing right here. Another picture of the myocardium, and another example of what we were talking about with the epicardium, they've broken it into even more levels that you don't need to know about. But the visceral pericardium, and as you can see, they're calling that the epicardium, that this whole section here, epicardium, parietal pericardium, they're breaking it into even more levels. But all you need to know is parietal pericardium. It looks like they're using epicardium and visceral pericardium interchangeably. And so if you put either one of those things down, I'd give credit for it. Okay. On a pin stuck on the outside of the heart and saying, what's this? Then the inside of the heart, myocardium in the middle. Okay. So just a few pictures I want to point out on the cartoons and normal or actual images of actual hearts. And that is when you're looking at a heart from an anterior view, I want to just point out what you see easily and what you don't see as well. So getting that heart oriented correctly is kind of critical. So you easily see the right atrium. It's usually right out there in the front, and the right ventricle are staring you right in the face. And when you see this sulcus, you know the septum is lying right underneath that. So the left ventricle has to be on the other side of whatever defines that that sulcus, whether it be fat or those blood vessels running down the center. So anything that's pinned over here might be left ventricle, this might be right ventricle. The only thing you can see of the right or the left atrium is this little auricle sticking out back here from the front. So keep that in mind. The pulmonary artery, as I mentioned before, sometimes confused with aorta. Look for what's coming off of these vessels. If you got three vessels coming right off the top, you know it's the aorta immediately. Okay. So those are just kind of some hints of identifying structures from looking at that.
It was kind of hard to see the heart from the front and the back to differentiate. Was there any tips you can to help with if it's the posterior or the?
I'm going to get to that in just a minute.
Okay.
Another slide coming up here in just a second.
Sorry, before that, is there a difference between interventricular sulcus and intraventricular sulcus?
Yeah, I don't think there is an intraventricular sulcus.
Oh, okay, makes sense.
Okay, so inter meaning between the two ventricles. Okay. All right, so this is obviously an actual heart, and again, you'd see the pulmonary artery here, the aorta going over the right pulmonary artery, but the trunk taking off at that angle there. Again, all of these that are labeled here are arteries. And I say that because I know people have struggled trying to name those the is it the great coronary vein, or what's the name of that big vein down the front? Anyway, the veins are collapsed and really very hard to see. So I think if it's a prominent vessel, it's more than likely going to be an artery, with one exception, and that's the coronary sinus at the back, where those veins become quite large. But the main vessels to remember in the coronary circulation are left and right coronary artery, the anterior interventricular branch, or LAD, or LCA. You can abbreviate those, and that would also be correct. and then the circumflex artery, which takes off around the backside. Then on the right coronary artery, that you have that big marginal branch that comes off. But otherwise, then it wraps around to the back of the heart. This ligamentum arteriosum is that one that we were talking about yesterday that was formerly the ductus arteriosus in the fetus. So keep that in mind. And then here's your telltale vessels up here on the top of the aorta, right atrium, etc. So if we look at the back, now you clearly see the left atrium. And that's the only way to clearly see the left atrium. And you ought to see these three pulmonary veins coming into it. So right atrium is somewhat hidden, but right atrium is large because it has a big capacity that it's bringing in the blood from lower extremities and from the head and neck and arms. And so the best way to really see the left atrium, other than the auricle, is on the posterior view. And that's one way to know that you're looking at the back of the heart, is to see this left atrium with 4 little vessels coming out of it like that, or going into it, I should say. And then your coronary sinus, which is usually pretty prominent, going into the right atrium and returning the coronary blood flow. I would think that's about the only coronary vein in the coronary circulation that you would be asked. Here's the same view in the actual heart. They've made it even clearer by filling the vessels with latex, blue latex for the veins and red for the arteries. So you can see that left atrium there with pulmonary veins, inferior vena cava, and big right atrium, and the coronary sinus. All right. So internal, I think anything you see it labeled inside the heart is probably going to be on a model. So we've pointed out before chordae tendineae, trabeculae, and the flow of the blood through the heart. So keep in mind that it goes through pulmonary circulation and the systemic circulation. Again, just drill on that, and each one of these structures that it runs through, past, over, around, I would keep in mind and learn them more or less in order. Here's the other fetal structure, closed, the fossa ovalis, and called a foramen ovalis in the fetus, fossa ovalis in the adult because it's closed, but a patent foramen ovalis in an adult if it's open, and that's a defect, obviously, that can cause a shunt of unoxygenated blood from the right heart to the left heart. Again, not quite as clear on the actual specimen, but chordae tendineae are pretty easy to mark. So you might get one of those tagged. Trabeculae, pretty easy. I haven't seen a moderator band out there, but that's in the right ventricle. If you just see a piece of myocardium going across the ventricle, you can count on that being probably the moderator band carries part of the conduction system. Septum down the middle, atrioventricular valves, and you don't really see from this opening the semilunar valves, but we'll look at those another way. Okay. Ryan, can you walk us through these structures A through E, F, G, H?
A is the superior vena cava.
Yep.
B is the right atrium.
Yes.
C is the right ventricle.
Yep.
D is the left ventricle. H is the left atrium. G is the pulmonary trunk.
Yep.
I'm not sure what F is, and E is the aorta.
Yeah. So pulmonary trunk is splitting right there. So it's the first big vessel that comes off is always going to be the left pulmonary artery,
Oh, okay.
because the aorta arches over the right pulmonary artery. Okay. Very good. Oh, where was I? I guess that's it. Okay, Gabriel, your turn. A through M. Sorry about that.
Sure thing. Yeah. Cool. A through M. It's gonna be a lot. Okay. Yeah. So A is the aortic. I want to say trunk. It's not the word I'm looking for, but that is
Let's call it the aorta.
sure. I'll call it the aorta. Sounds good to me.
Root.
G is the pulmonary valve.
Yep.
Wow, that's a lot. C is the right auricle. B, I believe, is pointing to the valve, which would be the tricuspid valve, if that's what it's pointing towards.
Yep.
Okay. E would be the trabeculi carni, if I said that correct.
D. No, I think that's part of the right atrioventricular valve or the tricuspid valve.
Oh, okay. So that's just all like the right, or that's just the tricuspid valve. Okay. Easy enough. H would be the pulmonary veins.
Yes. Mhm.
I is the opening to the pulmonary veins.
I
And
would just call that the left atrium.
sure. Okay. Left atrium. Yeah.
Yep.
I see. And then K would be the bicuspid valve, which then filters into the left ventricle. M is the interventricular sulcus, or is that only exterior?
Nope. Yes. Sulcus. Sulcus is a ditch or a hole. So this is septum. It's the septum device.
Okay. Septum. The interventricular septum. Okay. Eyes. I don't know. Part of the epicardium, I guess.
I'm sorry. Are you talking about L?
Oh, L. I apologize. Yeah.
Yeah, no, that's just myocardium.
Myocardium. Okay.
Yeah.
Myocardium. Is that the same with F then?
I guess you could say one is left ventricle, one's right ventricle.
Okay. Okay. Gotcha. I see. Did I get everything?
I
Am I missing something?
think you hit them all. Yep.
So what's
J is the aortic valve.
Oh yeah. Mm-hmm.
okay?
Yep. Okay, good. All right, this is showing the coronary circulation, what we talked about earlier. So if you can see it, it's probably an artery. That's the rule I would go with, but you know, you could get fooled. So, but just realize the veins are going to be small and flat if they're visible at all, and they're very hard to mark on a specimen, especially a cadaver, especially as beat up as these cadavers are. So, okay, so this is kind of to give a perspective on the cardiac cycle, and so just so you kind of get the concept of ventricular filling, which is obviously immediately after the heart contracts, it relaxes, it's repolarizing. Those valves just passively open up and allow the blood to dump in to the ventricles. And then right at the end of that dumping period, the atrium, the sinus node, goes off and sends an impulse around the atrium. They squeeze and shove the last bit of blood down into the ventricles. And as the ventricles distend, the pressure increases, and the filling starts to become what we call isovolumetric. So there's that pause in there between the atrial contraction and when the ventricles start to contract. So the ventricles then tighten up, which is called isovolemic contraction, where they just really kind of tighten up. They haven't started squeezing yet. And then all of a sudden they squeeze and the pressure goes up and slams those valves shut. And the pulmonary and aortic valves open. And the blood is ejected from those ventricles out those valves until the pressure equalizes between those vessels and the ventricles, and then those valves close. Another way to look at it, you get the sinus node, and it depolarizes the atria. And then there's a pause and gets to the AV node. So in the EKG, you have this P wave there, which is the atria depolarizing, a pause, and then the QRS, which occurs when the impulse immediately, very rapidly spreads down bundles of His and into these Purkinje fibers going in each ventricle and cause the ventricles to contract basically from the bottom up. So that's part of the reason why it carries that impulse very rapidly down this conduction system, so that the conduction begins at the apex and spreads toward the base of the heart.
Could the Purkinje fibers be marked on anything? And how would we, if it's so, how would we
You
find?
would be able to see them, and I don't think you'll be able to see any of the conduction system. They might have something tagged in the atria on the model, where I think they have something up there where the SA node would be, but there's really nothing to see. And if they tag something around the center of the heart, it might be an AV node, but they'd have to kind of tell you what they're looking for, because there's lots of stuff there, obviously, that can be confused on a real heart. I think in some of the models, they may have these colored So I guess they could mark some of those things that way.
Okay.
If at the most, I would think there'd be one question on that, if any. So it's just a little more. We had some questions yesterday about the EKG and what's occurring. And so I just put these in here if you wanted to go through the cardiac cycle. This is kind of cool, and it shows you where the heart sounds come from. The first and second heart sound. First heart sound comes from the AV valves closing. So right at the beginning of contraction where the AV valves slam shut as the pressure starts going up, and then the ventricular pressure goes up very high quickly, from 30 almost up to 120. And then when that pressure equilibrates with the aortic and pulmonary artery pressures, those aortic and atrial valves close, and that causes the second heart sound. That's where you get the dub, lub dub. Okay. You have actually third and fourth heart sounds, which are where the AV valves open, and it's just a dumping of blood back into the ventricles, and that percussion of the blood dropping in. They say you hear that more frequently in somebody with congestive heart failure with a stiff heart. Those are kind of some of the lost art of auscultation. We used to listen very carefully for that, and you could hear it, but nobody wants to spend that much time listening anymore. Just get an echocardiogram. And then this puts it all together: EKG, the interventricular pulse waves and aortic waves, and then volume, left ventricular volume, correlating with pressure. Pressure going up, volume going down as the blood's ejected. So those won't be on the test, but again, having those kind of concepts in mind help you think through other questions. So that's the heart. Any questions about that? Okay, we'll go through the blood. Red cells, there'll probably be a red cell marked on the test. So just know what a red cell looks like: biconcave cell, very symmetrical, very consistent in size and shape. This over here is showing some sickle cells, which is kind of interesting, as you all know it. Sickle cell anemia is exclusive to the Black population, and interestingly, evolutionary biologists will try to tell you this is an example of survival of the fittest, a mutation that helped to improve survival of people in Africa. That is somewhat true, actually, but it also points out another important fact. So people with sickle cell anemia don't suffer from malaria. And so when you look at a place where malaria is endemic, people don't die of malaria with sickle cell that have sickle cell trait. But it also points out that most mutations that occur break things. And so if you think of the whole concept of macroevolution and the fact that you've created, especially if you're thinking of origins of species from mutation, be highly unlikely, even in 4 billion years, to be able to get the diversity of animals in life that we see by mutations that make new things, especially when you've got to make so many changes at the same time to get one subtle change in a characteristic. So that's just an interesting concept, and what you're going to start seeing a lot more about is the fact that we actually tend to devolve more than evolve, and our mutations break things much more often than they create new things, which is essentially almost never. So this is your hemoglobin molecule, and 2 beta chains and 2 alpha chains. So that's where you're getting the beta and alpha at Gamer or Brian. I can't remember who brought that up, but so how many hemoglobin or how many oxygen does a single hemoglobin molecule hold?
4.
4, correct. And does hemoglobin carry more, or hemoglobin carry more oxygen or carbon dioxide?
And carbon dioxide.
No, more oxygen. Most of the carbon dioxide is carried dissolved in the blood. So carbon dioxide is very highly soluble in the blood. So I mean, maybe I might have worded that wrong. Actually, the concept I was trying to get to was most carbon dioxide is carried just dissolved in the blood rather than it bound to hemoglobin. Most oxygen is carried bound to hemoglobin and not dissolved in the blood. There's only a small amount of oxygen dissolved in the blood because its solubility is so much less than oxygen or carbon dioxide.
Does it matter which chain is where? Like, will there ever be 2 A chains at the top and 2 B chains at the bottom, or is it always crossed?
Kind of cross, yeah. No, I think that's the way the entire molecule comes together.
Okay.
Here's your white cells. Again, I don't see you being asked to differentiate these white cells, but you might just kind of become familiar with them. Lymphocytes are pretty easy to tell from the West. They always have a nucleus that is much larger than the cytoplasm compared to the others. Monocytes always kind of look like Pac-Man, and I always remember that they just run around cleaning up stuff in the blood, but have that big kind of arc-shaped nucleus, and they're big cells. Basophils stain dark, as we were talking earlier. Eosinophils stain red. They're the ones that are associated with allergies. You see a lot of eosinophils and allergic reactions, and parasites. And then neutrophils, bacterial type infections, lymphocytes, more viral infections. Antigens and antibodies. So remembering the ABO blood types, antigens are attached to the cell, the antibodies are what attached to the antigens. And so you get agglutination by the antibodies attacking the antigens on the outside of the red blood cell. Just like coronavirus, the spike antigen is what the vaccine is created against. So you've, in the Johnson & Johnson vaccine, you're actually giving the spike protein that the body recognizes as foreign material and develops antibodies against. Then when the real virus shows up with its spike protein, it attacks the virus with the antibodies that have been created and destroys it. So the 3 types of antibodies are A, B, and D is the Rh factor, which is plus or minus. You either have it or you don't, the D antigen. So this is just showing agglutination reactions and the fact that A positive is going to have agglutinate D and anti-A with the A antigen. B, same thing with the B antigen. AB plus, it's going to positive, it's going to agglutinate everything, all three antigens, and O agglutinates nothing. So who's the universal donor?
Oh,
O negative. And universal recipient?
AB.
AB.
AB negative, correct. Very good. This is more about functions of these cells. So I think the only thing you'd be asking about is red blood cells protect you as part of your immune system. Platelets provide hemostasis or create clots, stop bleeding, and red blood cells carry oxygen and CO2, right? Okay. And then I didn't have a slide last night for somebody was asking about RH factors in infants. And so I thought I might just review that again and found a new diagram because it has to do with ABO system. So if you have an RH positive father and RH negative mother, you can have an RH positive baby. So during the pregnancy, everything's fine because the blood elements don't mix. And so the baby is just happy with their blood separating from the mom's, oxygen's being exchanged in the placenta from the mom's blood to the baby's blood. The baby has red blood cells coated with the D antigen, but no harm, no foul, no problem. Then at the time of delivery, you get some mixing of blood because things rip loose, placenta comes loose, you get some of the baby's red cells mixed into the mom's blood and has enough antigen on it that it's recognized as foreign material, and the mom's immune system can become activated against the D antigen and form RH antibodies against the D antigen. Not a problem for the mom. She doesn't have any D antigen on her red blood cells, so there's no problem. But she's got these antibodies circulating around. Next baby comes along, another RH positive baby. The antibodies are small enough, they will cross the placenta barrier and get into the baby's blood and start causing problems. And you get hemolytic anemia in the baby. That's bad. So the baby gets into trouble in the womb. So the way they counteract that is after birth, they give ROGAM, or they give actually RH antibodies or NID antibodies to bind up those antigens on the red blood cells that the mom has gotten from the baby, so that her own immune system isn't exposed to them and doesn't react. So then you have another baby and the mom's has no circulating antibodies. So that's that. And that's the end of my story. Anything else you guys want to see or look at or have any concerns about? I think as far as questions go, the identification should be fairly straightforward. About half will be models and histology, and half will be on the cadavers. So you can just count on a pin being stuck in a thyroid gland, one in a pancreas, one in a adrenal gland, those are three easy ones that I know you all will get. You can get all the major chambers of the heart. Those ought to be pretty easy. The major vessels, aorta, pulmonary. Look for the hallmarks of those vessels to make sure you can differentiate them. And then the valves will probably be on the models, I would think. We only have, I happen to know that we only have one cadaver specimen that is cut open, unless they're pulling one from another lab somewhere, but I don't know that there is another one on campus. And that's that beat up one that we've already marked a couple times. It's kind of a flat heart. They might mark something on the posterior there, or maybe some chordotendinae or trabeculae inside there. It'd be hard to mark anything else very clearly on that heart. Let's see. The rest of those things would probably, like I say, be marked in the models. And then I think the last thing to realize, most of the didactic questions, there'll be a fair amount of endocrinology there. Just, what name two hormones secreted by the hypothalamus, name two hormones secreted by the anterior pituitary, name the hormone, what, where does insulin come from, or something like that. So stuff that we've been over pretty repeatedly. I don't think you see any surprises in there and stuff we haven't talked about and covered completely over the last 2 days. Okay. Brian, Goslin, you got any questions?
Just for the white blood cells, should we still memorize the other, how they are, in case that it does end up on the test asking for specification?
I think if you know what a neutrophil looks like, a lymphocyte looks like, and a platelet and a red cell, I think you'd probably be okay. Monocyte, the big ones that are just kind of obvious. I can't see them asking about basophils or eosinophils or any of those rarer cells like that. So those are all pretty straightforward. So I'll post this thing back out there. I couldn't upload it directly, so that's why I had to put the other one out on YouTube. I'll put this one out there, which should make it pretty easy to get to. It just takes a while for it to render after this is over with. But y'all should be able to look at that tomorrow and tell your colleagues where to find it. But I'll try to get it up there tonight. Okay. All right.
Okay. Thank you, Professor.
Sure. Thank you.
Thank you.
Good luck to you all tomorrow. I'm sorry I can't be there. But I'll see you next week.
Real quick question. When is the activity due?
The activity is due, let's see,
It's not before the exam.
October.
Okay.
Yeah, October the 3rd. So I guess it's this next Sunday.
Okay.
Oh, we're not turning it in through on Wednesday?
What's that?
We're not turning it in on Wednesday, like
You can.
before the exam?
Yeah, you can turn it in on Wednesday.
I meant like the paper, like, are we turning it in paper, or are we turning
No,
it
it's
in?
uploaded to the.
Okay.
Yeah. And you might check that once it's uploaded. I noticed that some people had missed a couple of questions and some diagrams disappeared off of there when they uploaded it. So I don't know what's going on, but I've sent those back to folks to if they want to go ahead and try and answer those questions that they missed or that were corrupted somehow, maybe. So, okay. All right. Good luck to you guys. I'll see you next week.
All right, thank you.
Mhm.